Go ahead and get into the panel, and we are really in luck because we have some amazing people today. So if we could start with Ayana, if you could tell us a little bit about yourselves and your story circle.
Hi everyone, my name is Ayana White. I am the Executive Director of Power and Changing. We are a diaper bank here in Columbia, South Carolina, and we service 4 counties within the Midlands. My pronouns are I, she, me, and our story circle consisted of single mothers who have had some type of hardships or currently going through some type of hardships. They all were on some type of social assistance and met the poverty guidelines that is set forth for the state and by the federal government. So they all had one common ground, that they were all going through hardships and maybe suffer from low income, but they came from a vast majority of different backgrounds, different races. So it was a great meeting of the minds, if you say. The takeaway that I would, the biggest takeaway that I got from the ladies is that they didn't feel that they were being heard. So that was something that came up repeatedly throughout the conversation, is that, you know, when they say something, either they weren't being heard or taken seriously. So that's our story circle. That was the biggest takeaway from the story circle.
Thanks, Ayana. Cora, you could introduce yourself.
Hello, good morning, everyone. My name is Cora Webb. My pronouns are they and she, and I am the program director for We Are Family, which is based in Charleston, South Carolina. We Are Family is a Southern grassroots nonprofit that provides affirming spaces for LGBTQ+ youth. Through peer discussion groups, we have a queer prom that we host annually. We have Trans Love Fund. We do GSA support services in schools, and we of course transfer over to the digital platform due to the pandemic and other things going on right now. Our group was comprised mainly of LGBTQ+ youth, so teens and young adults. And I will always also like to say that our group was predominantly white youth, because that definitely tells you, gives you information on the perspective that is taken on some of the questions and some of the group dynamics. The main takeaway from my group is that our youth want to feel safe within the home and outside of the home, if I could speak generally. Thank you.
Dory, if you would introduce yourself as well.
Good morning, I'm Dory Tempio. I'm with ABLE South Carolina, and my pronouns are she and her. And I'm so excited to be here. Our organization is a nonprofit organization. ABLE South Carolina works to empower individuals with disabilities to reach their highest level of independence, and works to promote community inclusion and access by working with community entities to make sure that things are accessible for individuals with disabilities. Our circle group consisted of individuals with disabilities of a variety of ages and cultural backgrounds, as well as sexual orientation. And it was an amazing group. The group really came together to talk about the fact, just as Cora said, that their voices are not heard when it comes to healthcare, and that our healthcare systems aren't accessible for individuals with disabilities, and they want to be included and empowered to be a part of the healthcare process.
Thanks, Dory. And now Jessica, if you would introduce yourself.
Sure, thanks so much for having me. I'm Jessica Tarleton. I'm an obstetrician and gynecologist in Charleston, South Carolina. I use she and her pronouns. In addition to providing general obstetrics and gynecologic care to patients of a lot of different backgrounds, I also specialize in the medical care, research, and teaching of family planning and infectious diseases in women. I led a story circle of medical providers who provide reproductive health care, including predominantly obstetrics and gynecology physicians, because that's the group that I'm a part of, but also reproductive health nurses and a primary care provider who specializes in women's and queer health. As some of the other panelists have highlighted, our panel was also, our story circle was predominantly white, so that does certainly color the responses that we got. I think the rest of the panel, I would really like to highlight the voices of the other groups, and we had such a variety of reactions to our story circle. I don't know that I could say that we have one takeaway, and I'll let the questions that we have in store kind of illustrate many of the points that we came up with.
Thanks a lot, Jessica. So the power to advance reproductive health rights and justice is not concentrated in the boardrooms and the courtrooms and the legislative chambers. The power to heal communities comes from within those communities. So Wren's Be the Voice South Carolina project aimed to uplift the stories of people who are trying to access healthcare services. We also wanted to build the capacity of communities to advocate for their right to control their bodies. So this project included 3 strategies. We educated policymakers on why reproductive rights are important. We created learning opportunities with reproductive health and rights activists. And we amplified the stories of South Carolinians on both the patient side and provider side of reproductive health care. So the 3 branches of the project, I thought it was important for y'all to know this. But again, our panel is going to focus today on the story circles. So these panelists were brave enough to speak out despite a culture of intimidation that was designed to silence them. This really speaks to the power of their voices. So when we're talking about that culture of intimidation, my first question to all of you panelists has to do with safety and speaking out. So activists and advocates know that there's powerful in amplifying the personal story. But speaking out really comes with risks. There's a culture of intimidation around reproductive health and rights activism. And I know that that came up almost in every group. So have you heard this term doxing? It's a sort of a jargony term, but doxing is when malicious groups with malicious intent take your personally identifying information and put it out in the web, like it's designed to intimidate people. And that can be a huge deterrent in people speaking out. Can you each talk about the risks and the safety concerns that came up in your groups? Cora, if you could start.
Yes, I would first like to say there's always, when you walk through the world with certain identities, you always have a safety risk of something bad happening to you, somebody targeting you because of who you are and you living out your truth. And so that same thing happens when you are a young person who's queer. And so there's already safety concerns with people attending our groups and their ability to attend our groups safely. So that's why we have certain youth that reach out to us and they say, I would like to come to your group, but I am not out and I do not have transportation or somebody that would take me to your location. And so with that being said, that energy is already there, and that is the premise before we even had the group, the focus group. So even with the focus group, you do have people who attended who may not have wanted their friends and family to know they were in attendance. So, and how we address that. So we are but one piece of our youth's life. So they go out into the world and they have to interact with people on a daily basis and interact with discrimination. So we talk to them about the things that they are experiencing, and we try our hardest to mitigate those issues with not outing them, with supporting them, with being with coming to our group, and just, you know, providing a safe environment for them to talk about the hardships of being out in the world and how they address some of the hardships that come to them. So yeah, thank you.
Thanks, Cora. This also came up in your parents group, Ayana, if you could speak to that.
Sure. So a lot of our moms felt if they shared their stories that it was going to have some type of negative backlash, meaning that they could lose benefits, that they're on any type of social assistance. So they weren't really they were kind of weary on how they could share this without it being them per se. So a lot of them were third party type stories, or I heard this happen. But ultimately, we had to constantly reassure the moms that this is a safe space. We're, not going to discuss much without, your consent, and you can talk freely. This is anonymous. So we did have that concern. Mostly, it was all about losing benefits that they received with, from state agencies.
Dory, your group with the disability community, oftentimes people try to speak over and silence folks with disabilities. So how did this culture of intimidation sort of show up in your group?
I think for our group, we experienced some of the same as Ayana's and Cora's. Number one, individuals were concerned about losing benefits. How would medical providers feel if they heard that they were sharing negative experiences? There was also some concern that people with disabilities often aren't seen as viable individuals in our society, that you would not have an opinion, that you would not experience anything to do with sexual reproduction. People with disabilities are often seen as asexual. So consequently, the idea that you would even be experiencing some of these events with doctors and medical providers, I had some people concerned if the information got out to family. Not all families are supportive of individuals being in relationships as well. So looking at all of the different factors, we made sure that people's information was confidential, that people had a safe space to share their information, and that they were reassured that their voices being heard was not going to be detrimental to receiving benefits and health care.
Thank you. Now, Jessica, I know the providers had a specific set of fears when it came to speaking out. So can you talk about that a little bit?
Yes, thank you. Safety, both personal safety and economic safety, were a big part of our discussion. Several of our Story Circle members are abortion providers, and so our physical safety and the safety of our families are very real threats and things that we also think about every day. As you know, violence and even murder has been perpetrated against abortion providers simply for being abortion providers. One of our providers had been personally doxxed before I knew what that meant, but that is what happened to her, where the photos of her and locations where she lived and worked were published online for the purposes of intimidation. And many of our Story Circle members also discussed the anxiety of trying to be an abortion provider and remain as anonymous as possible so that our identities were not publicized and our personal safety was not threatened. We also spoke a good bit about our economic safety and our economic stability and job security when we do speak publicly about reproductive rights. Some of us have been warned by the leadership of our institutions that public advocacy for abortion and other so-called controversial reproductive health issues could possibly jeopardize our employment. Which is one reason I'm not sharing my affiliation and my employer with you publicly today.
Yeah, thank you so much. And, people who have such an investment in inequality and oppression, if they weren't afraid of your power, then they wouldn't work so hard to silence you. So I just want to remind everyone of that. And thank you for being on this panel today. So there's some things that we can do as individuals to improve the healthcare system. So the next question is going to talk about that and then get into some more systemic systems level change that needs to happen. So, people with more marginalized identities in these circles reported feeling misunderstood and often disrespected in healthcare. Can you talk a little bit about how that showed up in your groups? And I think Cora, you had a lot to say about that.
Yes, I do. So, in terms of provider and patient relationships, I think one of the main steps that can be taken to mitigate misunderstanding is to normalize vulnerability with medical providers and to work to dismantle the hierarchy of knowledge in terms of our medical system. So, we as a society, as a culture, we understand that we think doctors have the end all say on all bodies and all lived experiences, and if they don't know what you're talking about, then you ain't experienced it, and basically. But that's not true. Doctors are not experts on everybody's lives, and so for my group of young queer people, they go to doctors' offices and are completely shut out of being able to talk about their bodies and their experiences because it's not a thing. So when you're a young person and you're basically competing for rights to say over your body with a professional whose word is held over yours, that already leads to a negative experience of you being able to access proper care, especially when you're trying to relay that a medication may not be working for you, or the treatment plan that you previously went over may not be working for you. And that's when believability plays into that. So as a young person, immediately you're being told, that's not true. Let me talk to your parent. I don't believe you. And then also, if you want to add on all these different layers of like socioeconomic status and racism, that's another thing. Race plays a lot into believability as well, as we know. So those things work into this ball of patients not being able to properly advocate for themselves and the treatment that they deserve. Thank you.
And then on top of it, I don't know if everyone has read the news that on the 4th anniversary of the Pulse nightclub shooting, protections for trans patients and LGBTQ people and Spanish-speaking people who speak languages other than English were rolled back. And so that makes us even less safe in the healthcare setting.
Yes. And I would just like to say, like, in regards to the protective laws being rolled back, how are people supposed to risk their lives going to doctors and going to these medical providers and take the risk to even see if someone is going to treat them fairly? That's a risk a lot of us are taking when we go to medical providers. The embarrassment of being told that you don't know what you're talking about, the embarrassment of being treated like you are not human, your dignity being stepped on, of not being told that what you're saying is true, your lived experiences are real. So people have to combat these things every day when they walk into medical providers' offices.
Right. Ayana, so Cora works with the youth, but your parents echoed some of these same concerns. Can you talk about that a little bit?
So yeah, from the story circle we had, a lot of the mothers felt like the doctors weren't listening to them as far as aches and pains that they were having, if they felt depressed about a certain issue, or it was just so fast because of the type of plan that they were on. A lot of our mothers, again, they're facing hardships, so they may be on a state-provided medical insurance, such as Medicaid, and so those doctors that are able to see them, which go far and in between, may be rushing to the next patient. So they didn't feel that they actually had a voice. If they did have a concern, it wasn't being taken seriously, or they felt rushed through the appointment. So a lot of stuff that are dealing with your, postnatal care or prenatal care, or just questions on the baby and just your body readjusting after having a child, which is traumatic in itself. It felt that they were just being rushed through and weren't being taken serious or even listened to. So if they didn't come in with a fever that day, if they didn't come in sick, it wasn't a high concern. And if all your signs looked normal, then they just moved on. So it just lacked a personal experience for that mom. And there could have been some underlying issues that could have been overlooked if it was just a good conversation had with the doctor, just to build that trust.
Right. And then Dory, like from the moment, you know, some of your participants in your story circle walked in the door, the equipment wasn't even accessible and things like that. So can you speak to that?
Sure, I'd like to go back even further. The medical model of disability has always said that you would be better without your disability and if they could fix you. So consequently, people with disabilities are often trying to explain to medical providers that they are happy being individuals with disabilities, that they lead very productive, independent lives. And we heard this through our participants as well, that medical providers, they may have a medical degree, but they're not the expert on someone's life. They don't live in that individual's body 24/7, 365. And so consequently, many of our participants shared that when you even try to dialogue with medical providers on your life, on choices that you want to make, on activities that you want to participate in, you aren't seen as a person who can do those things. So then you move it into the reproductive world, where we're trying as individuals to express our needs, our desires, our wants, even for children, our wants for active participation in the visit, and you're turned away. It's like you're turned off is what they're expressing. And that when they even tried to access reproductive care, many individuals can't get up on that table. And if they have to be weighed, which many of us do for our typical health care, we're not able to do that. So then you're asking people to take medications. You're asking people to do everyday daily health management. And if you don't have the accurate weight, you don't have the accurate measurements, how are you ensuring that someone's health is indeed being met? And I think lastly, our group spoke upon the idea of contraception. Doctors wouldn't even get into the subject with them. And I'm talking about adults in their 40s, 30s, 50s, because you just aren't seen as a being who would be having intimacy and sexual relationships. So the whole experience for individuals with disabilities can be quite devaluing. And I think that's something that medical care needs to change. And that was a big takeaway from our group.
Yeah, and you know, some of that, like in med school's curriculum, I feel like maybe some of that could be addressed in med school, but also, you know, I had the pleasure of sitting in on the provider story circle, and I heard some things that I didn't even realize that providers were facing. So just like the very short amount of time that they have, this short window of time they have to get so much into one visit. Jessica, can you talk about those challenges?
Absolutely. As medical providers in our circle, we definitely acknowledge that we have gaps in our knowledge and our training about how to address special needs in medical care. We specifically discussed at some length how to address gender identities in reproductive health care. And this, of course, was also kind of a self-selected group of people who want to do better. So there is still possibly a large contingent of the medical profession who doesn't even see this as an issue to be addressed. Cora, it impacted me so much the way you expressed the hierarchical relationships between medical providers and patients in a way that I feel but had never been able to put into words. And as we've talked about a little bit already, we also spend a lot of time talking about the limited amount of time that we have with our patients. Like we're given 15 minutes to meet, talk to, examine, prescribe treatment for, discuss a treatment plan, and write notes on one patient. And that given these time constraints, which are not chosen by us, but dictated by people who are making financial decisions, our brains can sometimes even behind the scenes, default to assumptions and stereotypes just for efficiency. And so that's a problem that we need to be addressed. And personally, every time I talk to this group of panelists here, I learn so much. Every time I hear them speak, my brain opens in a new way. And I think sharing these stories and these findings with medical providers would be really powerful, because they've been powerful for me.
Right. And I think, correct me if I'm wrong, but doesn't every group that you all represent on this panel offer trainings and lunch and learns and learning opportunities? Well, hey, there we go. Now, Jessica, you really touched on something that I want to pivot to. Now we're talking about systemic barriers. You just hit the nail on the head with financial concerns, right? This sense of urgency is tied to finances, which is tied to a culture of white supremacy. Urgency is a function of white supremacy. So money seems to rule everything, right? Money and healthcare. So almost in every group, cost was a huge barrier to getting that quality healthcare. So Cora, if you could start, maybe talk about that intersection of being young and queer and how that plays into the cost, which plays into lack of healthcare.
Yes. So, like you said, the intersection of being young and queer. When you're a young person, we already know barriers to getting a job, right? You're reliant on your guardians or your parents for transportation and for your basic needs to be taken care of. And also, as a queer person, we've had youth in our typical groups, some that did attend the focus group, but there's a fear of going out into the workforce and being discriminated against, of course. And so when you're looking for a job and trying to find a job that will use your correct name, use your correct pronouns, and treat you right and uplift your humanity, that limits, your ability to find a job as a young person, right? And so not only are you dealing with those large systemic issues, you're also dealing with your close-knit family and how they will prioritize your treatment and care as a queer young person. If your family's going through some financial difficulties at the time, they may put you getting your name changed, and this happens time and time again. They will put you getting your name changed and you getting your gender marker changed and you getting gender affirming care on the back burner. And I'm not saying that, I have no idea how financials work for many of the families that we serve, but that is a typical thing that, happens. And so you end up as a young person not having your own money to spend. And so that diminishes the pull and the power and the voice that you have in your family for demanding what kind of care that you should be seeking out, right? And so you relying on other people's access to resources ultimately diminishes your access to resources. And then for the youth who have parents who take them to doctor appointments and everything, when you do not have your own financial buying power, that leads a lot of parents to thinking that they have ultimate control and say to medical providers for what is best for their child and not listening to their child's wants and needs. So you may have to sacrifice your family paying for your care for your privacy, which is something that a lot of people cannot afford to do in terms of having intimate conversations with their providers. So there's a lot of back and forth between what is best between providers, parents, and youth in terms of their healthcare plan.
Yeah, and thank you for bringing up that employment and healthcare are so connected. Dory, I feel like that came up. That's something I was shocked to learn from you. Can you speak to that?
Yes. Systemically, our communities, our country has always seen people with disabilities as people that need to be taken care of. And that reflects in our employment opportunities. Nationwide, the unemployment rate of people with disabilities who are capable, ready, and want to work is 70% of individuals with disabilities are unemployed. Consequently, that makes it really hard if you're not being given employment opportunities to be able to work. If you can't work, then you can't get insurance. There's also this misnomer that people with disabilities don't want to work, which is not true also, and that people with disabilities all want to be on benefits. Now, there are those who need them to be sustainable in life, but that doesn't mean they don't want those opportunities. Also, when you are on benefits, most people with disabilities in this country live at the poverty line. So consequently, the medical care that they need as a person with a disability is usually unattainable. If you need to see specialists, if you need assistive technology or adaptive equipment, you're lucky if you can get one piece of equipment every 5 years. And that can be really difficult. So we're asking people who have health conditions that do need to see specialists, who do need to have adaptive equipment, who do need medications to live, and they're not able to get them. And so consequently, our healthcare system is not built to serve people with disabilities. Also, if you fall into other marginalized groups that Cora and Ayana have mentioned, as well as Jessica, that makes it even harder to access medical care. And if you try to speak with someone about your sexual orientation or your cultural preferences, our group brought to light, people don't know how to have those dialogues, or they try to deny it because they think your disability doesn't make those things possible or needed.
Right.
So we have a lot of work to do there systemically.
Oof, yeah. And Ayana, you know, a lot of the parents in the group that you were working with are not paid nearly a living wage, right? So like, how does this affect them?
So you have a lot of parents who rely on their pregnancy to see their OB, and that's what they consider their doctor. So you have a lot of women who who have a pregnancy, they got pregnant, and this came up a lot in our group, just to see the doctor, because if they didn't qualify for Medicaid, they could not afford any other form of insurance because of how they work. They may have a part-time job, may have other children. So it was a very kind of no man's land for these women as far as seeking out medical care and getting that on a regular basis. You also have access to care, which was limited them going to the doctor. When you're in a rural area, such as we're in South Carolina, so you know there's a lot of farm ruralness around us, and with hospital closures, just going to see a gynecologist or going to see an internist, anybody, those doctor's offices are being closed, and access to transportation is kind of, you know, impossible to do that. So it was a very interesting and eye-opening conversation that, you know, that women were really relying on their pregnancy, that 10-month period. I know it's 9 months, but 10 months of you going to the doctor during the pregnancy and post to really get care for health issues, where that is just one particular area of your body, not your whole entire body. So there's a lot of underlying issues that are not being met, and they're not going to a family practitioner. So it was very concerning and alarming to find that out, even with Medicaid. So.
And Jessica, wow, the providers had a lot to say about how money interferes with the way that doctors can provide healthcare. If you could speak to that.
Yeah, I mean, I think as medical providers, we touched upon all of the issues that our panelists highlighted. We do recognize and see those things from the other side. Like Ayana said, we definitely appreciate that patients who are on Medicaid for pregnancy, that is our window of opportunity to try to address a lot of issues that are not necessarily pregnancy specific, but while we do have that time with those patients, we try to take care of a lot of things. but it is, as a medical provider, something that you don't learn in medical school is the additional layer of medical decision making that is dictated by insurance and the cost of care. So after you've learned about a patient, talked to the patient, decided upon a treatment plan, we then every single time have to find out what kind of insurance that patient has and whether or not their insurance will cover the treatment plan that we have decided upon. And even if they do, if they will be able to afford the copay. And if that patient is uninsured, of course, some medical treatments are just out of the question. There's a lot of care that we provide, like abortion care, that is just uniformly in the state of South Carolina not covered by insurance. And so we see many instances where patients only access that care if they physically have cash in the pocket. I don't have a lot of answers for that right now, but all the factors that the other panelists brought up are very true in our day-to-day lives as well.
Right. And this information is good. It will help us inform our advocacy efforts. I dropped a question to the audience. In what ways has cost prevented you or someone you love from accessing reproductive health care? So as much as we can, if we have time at the end, I'm going to uplift some of the conversation in the chat box. So marginalized folks, communities with marginalized identities, people who aren't earning what they're worth or earning near a living wage are more impacted by attacks on reproductive health care. When we think about that, I think of defunding policies that are taken against contraceptives, STI testing, or abortions. So in what ways have our state laws impacted reproductive health care for the people in your groups? Ayana, if you could speak to that.
So during the time of our group, it was when the fetal heartbeat bill was being played around with. And I say that loosely, but that was a scary moment for a lot of our moms that came to see us, because they really talked about not having a say if they were to get pregnant, having a choice in the matter, and what to do after the child, if they had to keep the child, what to do after the fact. I can't afford it. I'm already, have multiple children. We're trying to navigate this hardship that we're going through right now. What am I supposed to do? So a lot of what came up was that pretty much that fetal heartbeat bill and how it affected them, and how it was eye-opening to a lot of the mothers in the group, that legislators or policymakers could make decisions on something so personal and intimate, such as their right to either carry through with the pregnancy or terminate.
Right. Wow. Okay. Cora, I think the laws have touched your group in different ways, not necessarily directly impacting healthcare. Can you speak to that?
So one thing I would like to say in terms of this question is we live in a white supremacist, racist, capitalistic, on and on and on society that is wreaking terror. And so all those things are inherently embedded in our laws. And like I said, wreak terror on us, as we can see. And so for my use, I like to pinpoint sex ed in schools. So, lack of comprehensive sex ed, and that's for everybody across the board, but specifically pertaining to queer youth. When you don't talk about the diversity of bodies and gender identities and sexualities, it teaches you that your humanity does not matter. And your life is not uplifted. So how are you supposed to go from school, the school setting where you're not taught about yourself, to a conversation with your medical provider about what you think is best in terms of your treatment plans and everything else? And so when you don't have information about yourself, you lack the language to accurately portray what's happening in your body, and what you feel like you need for a healthy life. And so that's one of the main things that I see transfer over from school to the doctor's office with my youth. They're not seeing themselves in school curriculum. They're not seeing themselves represented. And then they have the burden of having to advocate for themselves, or even their parents having to advocate on behalf of them when they are not provided the information from the school setting where they spent most of their time, which does not make sense at all. So that's one of the things that I would like to lift up.
Right, right. And Dory, the laws for the longest time really tried to take away the autonomy of people in the disability community's right to parent. So
Exactly. I also want to echo what Cora said. She said a lot there, which I think we all could unpack. Number one, she said that individuals in our state do not receive sexual education. That's important. If you don't know about your health, you don't know how to manage your health, you don't know how to manage your sexual reproductive rights, how are you supposed to get through life, really? And think about that. As well as what Cora is saying, we had people in our group of multiple marginalized groups who do not receive sexual education because they are people with disabilities in self-contained classrooms. And then they come out, they're in the community, they contact Able South Carolina, and they're not sure. They're like, I might be pregnant. I may have an STD. I'm not sure. What do I do? I'm not sure if I'm in a healthy relationship or not, because they have never experienced that education. Then you have people who are LGBTQ plus, and we're not addressing any of that either. And we kept hearing from people of all ages and all marginalized groups that intersected with disability that that was one of the most damaging things in their life, not having access to that. The assumption that they didn't need it, that they didn't want it, and that it wouldn't help them overall in their lives. And then looking at it from another perspective, I don't know if many of you are aware, up until May of 2017, individuals with disabilities, if you had children, could have your children taken away from you solely based on disability. People think of disability and they think of a physical disability, but disability encompasses many different categories: psychiatric disabilities, learning disabilities, hearing disabilities, visual disabilities. Anybody with any health condition has a disability. If you have asthma, you are a person with a disability in this country defined by the law. And you could have your child taken away from you solely because of disability, not because you did anything wrong, not because you are a person who hurt your child. So in 2017, I'm proud to say our executive director partnered with many entities around the state to have the Persons with Disabilities Right to Parent Act passed, which allows individuals with disabilities the right to parent, the right to access adaptive equipment and assistive technology to parent, to work with agencies like DSS and DHHS to give people the skills that might need to parent that use adaptive equipment and other technologies to be a parent. And that's a must, but we also have to combine the other aspects that Cora, myself, and Ayana have spoken. If you're not doing that, we're doing a disservice to individuals of marginalized groups in our state.
right, thank you. Thanks for uplifting that. It's also important to support to celebrate our victories. So thanks for working so hard to get that law passed. And Jessica, I know that laws influence your ability to provide healthcare every single day. So can you talk about that?
Sure. We as a group could have talked for hours about legal and policy restrictions that hinder our ability to make medical decisions about reproductive health care. And while we're talking about some fundamental principles of healthcare, I'd like to say that I think these laws are based on the valuing of women as valuable only for reproduction and for vessels for babies, and that they are not valued or seen to be important to take care of as autonomous individuals. And that could probably be said for many of the other marginalized groups that our panelists represent. But that's a very big topic. Laws in particular that we discussed, there are, pages and pages of what we call TRAP laws, or targeted restrictions against abortion provider laws. Ayanna talked about the fetal heartbeat bill that was proposed in South Carolina. We have a 24-hour waiting period in South Carolina after a woman has to read some state mandated educational material that is biased and in some cases medically inaccurate before they are seen to be informed enough to make a decision about whether or not to carry a pregnancy. We discussed the restrictions around providing sterilization or tubal ligation procedures to patients who have Medicaid, in which for only patients that have Medicaid insurance, we are required to have them sign a consent form 30 days in advance of a sterilization procedure, which originally was meant to protect women with Medicaid insurance from being sterilized against their will or with inaccurate or inadequate consent. But now we find it is a barrier that is unfairly borne by only women who have lower income. We talked about also the dubious honor of South Carolina being one of the only states in the nation to prohibit medical providers from prescribing partner therapy for sexually transmitted infections to our patients. And so what that means is that it is recommended by many of our medical societies and recommended by the Center for Disease Control, for example, that when we diagnose a patient with a sexually transmitted infection, that we give that patient a prescription or a medication for them to give to their sexual partner so that they can both be treated. And in South Carolina, that is not allowed. So many issues, many fights to fight.
Wow. So we may have a couple of minutes toward the end to, if you have any burning questions, audience. So if you want to drop a couple of burning questions, if you have those, into the chat, we will try to get to them. I have a question that I'm going to pose to the audience as well as our panelists. How can South Carolina lawmakers better support the reproductive health care needs of women and LGBTQ+ people? So let's dream big here. Let's pretend that we can get what we want. So Cora, what do you think?
I would say amazing question. I would ask them all to step down and allow other people to fulfill their roles, because they were utterly refusing to do their jobs of supporting common everyday folks, and they are money hungry. They only fill their wallets with corporate money, and they do not listen to common people. And we can apply this. This is a very general statement that can be applied to almost any of our representatives that refuse to listen to and vote against us. And so, like I said, replace, step down, be replaced. That's what I say. If they really want to take a step to better support the reproductive healthcare needs of women, queer peoples, any peoples in here, around here. Thank you.
Right. Ayanna.
So I echo Cora, but I also want to say that make sure they have medical professionals at the table who know what they're talking about when making some of these changes in policy, because they are the connection to the people, and and they have the medical background. So listening and having them at the table, maybe taking a major role at the table, not just being there, that would be beneficial in my opinion. And that's what I kind of feel as a takeaway, sorry y'all, takeaway from the group as a whole, that they just felt that their doctors, that the doctor should be present and more into the managed care.
Dory.
Thank you. Our group had some really concrete answers to that question. Number one, they felt physicians should receive more training on working with individuals with disabilities from a social model rather than the medical model. They also felt that medical professionals really need to look more at language. People with disabilities use what's called person first language or identity first language. And often an example of that would be the word special needs. Special needs was not created by people with disabilities. It was created by the educational community, and people with disabilities don't like that language, because why are our needs any more special than anybody else's? Everybody has needs, and we all should try to fulfill those needs, whatever someone might need. And they feel like the word disability is seen as an ugly word in our society, and it's not. People with disabilities are proud to be individuals with disabilities. So we would like people to just say people with disabilities or people without. Young people with disabilities, young people without disabilities. It's not something to see as a negative. And I think lastly, what they really wanted was some policy or mandates for medical professionals to have adaptive equipment for providing medical services to individuals with disabilities. How can you provide quality services if we aren't using equipment that gets to the heart of what people's conditions may need or be impacted? And so those were the three big takeaways from our group. Thank you.
You, Jessica.
Our biggest request is for lawmakers to allow medical decisions to be made between doctors and patients and not by laws or by policies. We may have our own biases and problems that we need to address as a medical profession, but we're the ones that are sitting in front of the patient, and we don't need laws to tell us how to make decisions.
Right. So with the last few minutes, there were two questions that came up in the Q&A box that we can explore. One is, how can individuals through their respective groups develop brochures like Q&A brochures to affect change in getting clear answers to basic medical treatment and health issues? So basically, how can individuals help develop like question and answer materials, whether it's brochures, to affect change in the healthcare setting?
I mean, you could get involved with an organization like REN or any advocacy organization. I mean, that would kind of just and put your opinion or your thoughts into it and just come with a collective plan. That's how things get motivated and change starts, with groups like this, having conversations like this. So that's how I would answer that.
Yeah,
that's exactly what I was gonna say. Like, look at what REN is doing right now. This is amazing information. Let's use this information that we got from these story circles, package them somehow to, and this is the point, but, package them to stakeholders, to medical providers, to better educate us on what you need.
right.
And I would also add, bring the people to the table who it impacts. So if we want to do things with medical providers, bring the people that this is impacting together in either a larger group that would actually sit down with these folks as well as policymakers to address some of these issues. Because when you're hearing it from the people it directly impacts, I think it truly makes a difference.
And I so agree with you, Dory, because that's what we're only reporting what we heard. We're not reporting, you know, our opinions. We're reporting, I mean, some may have been influenced, don't get us wrong, but we are really reporting what came from the circle group, from the story group, and from some real questions and hard questions that was mediated through Ren, and they recorded it, they understood, they wanted to understand more of how the public feels, especially marginalized people feel. So, you know, we're just reporting back. This is just us reporting back to you guys.
Didn't the disability coin the phrase "nothing about us without us"?
Yes, ma'am. That is by the disability community. Nothing about us without us. And the idea that disability rights are human rights.
That's
and
right.
So all of us have rights. And so all of us could actually be in that quote. We could just insert our particular groups that we worked with. And I think that sometimes gets lost in the grand scheme of things, that everybody here has rights and we all should be a part of the process of trying to correct things and find solutions.
Right. So we are at the end of our time together. There was a question about how do we inform policymakers about doxing? That's a great question. I think they need to know. Cora, you have something?
Yes, I just wanted to give a little insight to the question. So the question was, do you think SC policymakers need more information on doxing / the risks of speaking out? How do you see their role in protecting constituents from doxing? And I would just like to inform the public that policymakers are very much so informed about the impacts of the things they say when they incite violence. Because it's them and their supporters who are doxing and harming other people who are opposing their views. So I think maybe they need more information on the actual term doxing and what that entails, but the the system of discouraging people from speaking out is already there. That foundation is already laid, which is why some of us, have that fear already of speaking out, because we know what can happen when you challenge policymakers and people in power. So that's all I wanted to say about that.
Thank you so much, Cora. I'm gonna go ahead and close us out. So big, huge thank you for all who participated in this panel and the project as a whole. We've already seen new energy springing out of the work. So if you were involved in this year's Day of Action for Bodily Autonomy, it grew from our activist group and our story circles. Removing financial barriers to advocacy was a big step in propelling reproductive health and rights forward. There are so many ways to increase the momentum of this project through continued relationship building, shared learning, and amplifying the stories of the people who face the most barriers. So the people have always had the power. The people who experience the most marginalizations are the ones that you need to listen to if we truly want meaningful change. So with that, I will end, and thank you so much for participating in this panel, everyone.
Thank you for having us.
Thanks, Ren and Melissa, for having us. This has been such a meaningful project for me to be a part of.
Thank you so much for having us. It was deeply insightful and powerful and empowering for the people who participated. So we really appreciate you including us.
Thank you all for participating with me and moderating this. Thank you. Keep up a good fight.
Oh yeah.